Hello and welcome back to our continuing new CME conference series on pain management. We have some more talks continuing next week, including Dr. Vielma, who's going to speak on palliative care update and palliative care topics. We have Dr. Weinstein from USC, who will be presenting on the psychology of chronic pain. But today we have an interesting topic, something that's very common really across most specialties, probably the number one reason, or the top reason that patients seek consultation, and that's chronic low back pain. Dr. Reginald Ajakwe is going to present a review of this topic and shed some light on it. Dr. Ajakwe is on the Buena Vista Anesthesia Medical Group. He's a partner in anesthesia here at the hospital. His training started at UCSD Medical School. He continued on to Columbia University, where he obtained his residency in anesthesia. And then from there, fellowship in pain medicine at UCLA. Dr. Ajakwe is board certified in anesthesia and pain. And I'd like to welcome him to present this topic.
Thank you for the kind introduction, Ray. I'm going to be speaking about chronic low back pain today. This is a very diverse topic. My goal today is just to give an overview of chronic lower back pain and discuss some of the most common diagnoses we see on an outpatient basis. Some statistics. Chronic lower back pain is the fifth most common reason patients see us in the office. It's only second to upper respiratory infections in terms of symptomology. Very common in the population. About 50–80% of adults experience low back pain. It poses a huge burden on society. The direct and indirect cost to societies is estimated at $50 billion, and this is from 4 years ago, so it's probably higher than that now. There's a widespread belief that most patients get better within 6 weeks. However, a lot of studies show that irrespective of treatment, a lot of patients still have residual pain and disability up to a year later. So what kind of things can predict low back pain? Here's a list here. As you can see, most of these listed items are modifiable. These are modifiable factors. So we have a huge opportunity here in trying to coach our patients to modify some of these habits. The only thing that's not modifiable is probably increase in age. Here are some predictors of chronicity and disability associated with low back pain. They include things we might expect, like radicular leg pain, poor coping strategies, anxiety levels, lower activity levels. Also, there are several things here that are modifiable. This is also another opportunity where we can actually coach and advise our patients to change certain habits so they can reduce their susceptibility to chronic lower back pain. There are different ways to classify chronic lower back pain, but I like to classify it based on whether it's mechanical or non-mechanical. Mechanical lower back pain usually is defined as overuse of an anatomic structure that results in either strain of a muscle or a ligament. This is by far the most common reason or most common cause of chronic lower back pain. And there's 10% of patients who have chronic lower back pain from a non-mechanical etiology. Usually it's a symptom of a more systemic illness. So we now have this responsibility as physicians to be able to distinguish those patients, those 10% with chronic lower back pain as a systemic illness from the 90%. We don't want to miss those 10%. So I'm going to spend the next few minutes talking about some signs and symptoms and modalities we can use to identify those 10% of patients who don't have mechanical chronic lower back pain. On the initial evaluation, onset can typically give us clues. Usually, if there's trauma or a period of excessive stress activity, it's probably mechanical. Duration and frequency. Systemic disorders cause chronic back pain that's more persistent. Mechanical lower back pain is more episodic. The location and radiation of the pain can give us some insight as to where the pain generators are. Typically, aggravating and alleviating factors characterize the mechanical quality of the pain disorder. Other things on the initial history include the time of the day with the maximum degree of pain. Some of the more common inflammatory disorders are usually worse in the morning stiffness, for example, rheumatoid arthritis. The quality of the pain can also help, but not necessarily distinguish between mechanical and non-mechanical, but it can tell us what type of pain it is. Is it neuropathic? Usually that's burning pain, or electric shock, as our patients might describe it, versus musculoskeletal, which is usually aching. The intensity of the pain, the degree of pain, or the pain rating by the patient does not give any insight as to whether it's mechanical or not. It just helps us follow the patient and tells us if the patient is improving or not. Some other factors include fever, weight loss, which might be a sign of systemic etiology for back pain. Nocturnal pain and pain with recumbency is usually a ominous sign. A lot of our cancer patients will be absolutely well controlled with pain during the day, but at night they will have intractable exacerbation of their pain. Nobody knows why. I mean, there have been different proposed mechanisms. Some people think that it's because of increased blood flow in the supine position at night, but there are no studies to prove that. Other things we look at are localized tenderness in the over the vertebral column. That can often be an indication of a vertebral fracture, usually from a systemic process, either from increase in mineral loss or replacement of normal marrow tissue with inflammatory cells, as in cancer. Either way, both processes lead to weakening of bone and bone breakage spontaneously or with minimal impact. So how do we work these up? Obviously, you need a detailed history and physical exam to identify some of the things we've discussed a few minutes ago. Usually, most of these patients do not need any aggressive interventions or any imaging studies. They usually can get better very conservatively in 4 to 6 weeks. They need reassurance. A lot of them come in very anxious and scared. They need to be reassured that most of the time back pain does not result in disability. Over-the-counter NSAIDs can be helpful. Tylenol can also be helpful. If symptoms recede in 4 to 6 weeks, then no further workup is needed. However, if symptoms stabilize to unacceptable levels, usually those levels are determined by the patient and the physician together, then additional workup might be indicated. These might include plain radiographic films. An MRI should also be considered in the modality. If the patient cannot tolerate MRI because of a significant amount of hardware in the spine, or if we're looking more at a bone pathology, then CT might be considered. Early surgical consideration should be given if there's evidence of severe neurological damage or symptoms of caudal equina. All right. I'm going to spend the next few minutes talking about non-mechanical back pain. And whenever I see a patient in clinic, I always think about this movie. I always try to ask myself, what's the usual suspect here? Or who are the usual suspects? It's one of my best movies. So here they are: lumbosacral strain, lumbosacral arthropathy, lumbar syndrome, sacroiliac joint dysfunction, piriformis syndrome, spinal stenosis, and ischiogluteal bursitis. I'm going to spend the rest of the time talking about most of these conditions. So lumbosacral strain. Typically, this is your out-of-shape, middle-aged gentleman who's tried to move furniture around over the weekend and comes to your office. Doc, my back is killing me. So what do you typically see in these patients? You see a localized area of pain. You see pain that occurred simultaneously with some kind of increase in activity, such as picking up a couch. Decreased range of motion and reflex contraction of the involved muscles are typically present. And there's always exacerbation of pain with contraction of the involved muscle, usually caused by a muscular or ligamentous injury, continuous mechanical stress from poor posture, and small tears in the annulus fibrosus can also cause this. Physical exam findings. Well, the most important line here is the last one. These patients have normal neurologic exam, first and foremost. Other things that you look for are trigger points might be present in the area of the involved muscle. Obviously, there's going to be pain if you do any maneuvers that contract the muscles involved. Treatment. Usually conservative, controlled physical activity. First-line medications are usually NSAIDs and centrally acting muscle relaxants. With regards to activity, a lot of patients always want to know if they can go back to normal activity. The recommendation is yes, normal activity as tolerated, but nothing excessive. Trigger point injections can also be helpful in these patients. These are usually done either by dry needling, or you can also add local anesthetic with or without a small amount of steroid for your trigger point injections. And these can be done in the office. All right, the next one is sacroiliac joint dysfunction. The anatomy, it's a picture here. Basically, the sacroiliac joint is a joint between the sacrum and the two wings of the ilium. It's a very large joint. It's actually considered a diarthroidal joint, which means that the adjacent bones are lined by cartilage. The joint contains synovial fluid. The joint has a synovial membrane held together by some fibrous capsule, and there's also some free movement within the joint. Innervation of the SI joint is very, very complex. The posterior portion of the joint is innervated by the posterior primary rami of L4 through S4, and the anterior portion of the joint is innervated from the ventral rami of L5 through S2 via the branches of the sacral plexus. Some statistics about it. About, I'd say 15–30% of patients with back pain can usually have sacroiliitis. They're usually actually misdiagnosed, in my experience. The sources can be intra-articular or extra-articular. For example, infection or arthritis is usually intra-articular versus fractures or ligamentous injury. Some factors predisposing to this condition include leg length discrepancy, gait, prolonged vigorous exercise, etc. Scoliosis, trauma, pregnancy, and spinal fusion to the sacrum. Most of these factors are not modifiable, unfortunately. Signs and symptoms. This is one diagnosis where the physical exam helps, but it's not a slam dunk. The most consistent sign is localized pain in the lumbar spine beneath the spinous process of L5, and there's typically point tenderness over the groove of the sacroiliac joint on the affected side. There are a few provocative tests that you can do to help you gain more confidence with the diagnosis. The most common is Patrick's test, also known as a Faber test, flexion, abduction, external rotation. But again, not even these tests are specific or sensitive enough in the diagnosis. The diagnosis has to be done, before I go to that, with regards to symptoms, imaging is not very helpful. I see a lot of patients who come to me with, who think they have SI joint dysfunction. They want to get an MRI or a CAT scan or X-rays. I mean, most of these patients with SI joint dysfunction have no signs on imaging. So imaging is very useless when it comes to this diagnosis. The diagnostic modality of choice, I'm looking for that here. Anyway, the diagnostic modality of choice is an intra-articular injection of local anesthetic into the SI joint, small volumes, about 1 to 2 cc's. If pain resolves after that injection, then you can with some high degree of confidence, establish a diagnosis. By the way, that injection can also be therapeutic in addition to being diagnostic. Treatment modalities include a multimodal approach. NSAIDs help with inflammation, physical therapy, especially working on a postural realignment. SI joint injection with fluoroscopy using local anesthetic and steroids. As I said, this can be diagnostic and as well as a therapeutic maneuver. And then there's radiofrequency ablation of the docile rami nerves, L4 and L5, as well as the S1 through S3 lateral branch nerves. If you guys remember, the innervation of the posterior aspects of the joint is through these nerves. Now with radiofrequency, you're only destroying the posterior innervation. If this is a patient that has pain from the anterior innervation, they're still going to have pain even after this procedure. Some people also perform direct denervation of the SI joint with radiofrequency as well. This involves putting the probes directly into the joint and doing skip lesioning of the joint. Our next one is the piriformis syndrome. Some anatomy here. The piriformis muscle, it's a pyramid-shaped muscle. Usually originates anterior to the S2 through S4 vertebra and inserts onto the superior aspect of the greater trochanter of the femur. It courses through the sciatic nerve as it inserts into the femur. There's some developmental variations between the sciatic nerve and the popliteal, and the piriformis muscle that might account for some of the this syndrome. Essentially, in 20% of the population, the belly of the muscle might be split by the nerve. You can imagine if that happens, if the nerve courses through the split, that any abnormal contraction of that muscle might put pressure on the nerve, hence generating a painful sensation. There's usually a 6-to-1 female to male predominance with this syndrome. In half of the cases, there's a direct trauma to the area of the piriformis muscle. Certain sports predispose individuals to this. Things like cycling and tennis. Cycling because they sit on their butts for a long time, and tennis because of the constantly internally rotating the hips, which causes increased contraction of the piriformis muscle. Clinical presentation, usually there's deep aching pain in the buttocks over the affected area. The pain can radiate to the hip, lower back, posterior thigh, but rarely below the knee. Although it can, I've actually seen it radiate below the knee several times. As you can see, this might make a diagnostic dilemma in a patient who has coexisting foraminal stenosis or facet arthropathy, which I'll talk about later. But the referral pattern for a lot of these conditions, there's a lot of overlap between them. So just keep that in mind. Often there's a limp on the affected side. There's certain tests like internal rotation of the extended thigh that can help with the diagnosis. Treatment again is physical therapy. There's a piriformis stretch usually is encouraged to help decrease the amount of tension on the muscle. Pelvic tilt. Medication therapy with NSAIDs can sometimes be helpful. Intramuscular piriformis injection with local anesthetic and steroids usually helps serve as a diagnostic maneuver, but can also be therapeutic. Usually they need repeated injections, maybe 2 to 3 weeks apart, to break the cycle. Recently, injection of Botox, about 100 units into the muscle after a diagnosis has been established, has been found to be helpful for sustained relief. All right, so the next one is, this is very common, lumbar facet arthropathy. Prevalence is very high, 10 to 15% of patients with lower back pain usually have lumbar facet arthropathy as their diagnosis. Usually this is an age-related disorder. As we age, our facets, the orientation change from a more coronal to a more sagittal position. this adds more stress to these joints. Usually the most involved joints are L3-4, L4-5, and L5-1 in the L5S1 in the lumbar spine. Each facet joint is actually formed. Let me pick the anatomy here. Each facet joint is formed by the superior articular process and the inferior articular process of the corresponding joint. Let me just show you here. So over here, that's the inferior articular process, and this is a superior articular process. So both of them form a facet joint. You can also see the innervation of that joint, which we'll talk about later, innervated by the medial and branch nerves, which come off the dorsal ramus. Each joint has a typical structure of a synovial joint. The joints are innervated by the medial branches of lumbar dorsal rami, as I mentioned earlier. The innervation is from the ipsilateral medial branch nerve at the level of the joint and one level above. And that comes into, that's very important when you're trying to treat this syndrome, as I'll discuss that in a few minutes. But just as an example, the L4-5 joint is innervated by the L3 medial branch nerve and the L4 medial branch nerve. History and physical. Like many of these conditions, there's not any particular physical exam finding that can establish a diagnosis for you. Some negative findings that might help you include pain not relieved when rising from a forward flexion, pain not exacerbated by coughing, pain well relieved by recumbency, and pain not worsened by hyperextension. The diagnosis of choice, though, the diagnosis test of choice is a median branch nerve block. Essentially, what that involves is injecting about half a cc of local anesthetic over the nerves that innervate the joint. So over there and over there. And this is typically done under fluoroscopy. You can use lidocaine or marcaine. If back pain is relieved after that injection, then you can reasonably establish that diagnosis. Here's a referral pattern for facet arthropathy. As you can see, radiation to the groin, to the buttocks, and to the legs as well. And many of the disease processes that we encounter on a regular basis for chronic lower back pain refer to the same places. Treatment. Usually these patients need a multimodal approach. They've been in pain for a long time. They not only need medications, they might also need some pain psychology, some physical therapy. Those are usually things that are tried first initially. And then some of the more advanced treatments, something like radiofrequency ablation of the medial and branch nerves. Again, that's only performed only after the block with local anesthetic has been done to confirm the diagnosis. The radiofrequency ablation is done percutaneously, and it's an outpatient procedure. Intra-articular steroid injection is rarely done nowadays for treatment of facet arthropathy. For one, the joint space is very, very small and usually eroded. It's very hard to inject any volume confidently into the facet joint space. So median branch block is what's used nowadays. Lumbar radicular syndrome. Most of this is usually caused by herniated disc or some kind of degenerative spinal disorder in about 98% of the time. The incidence of patients with lower back pain who have radicular symptoms is about 12 to 40%. Radicular pain can be a feature of radiculopathy, but is a separate condition from radiculopathy. Radiculopathy implies that there has to be some type of motor dysfunction, sensory anomaly, loss of deep tendon reflexes, or a combination of any of the three. So what causes this? Usually, anytime there is a herniated disc material in the epidural space, this can become a very big irritant for nerve roots in the epidural space. It can sensitize the nerve roots to produce pain. There's some proposed mechanisms from increased compression from pressure, vascular compromise, and also inflammation and biochemical influences. Signs: back pain can be a major symptom, but usually there's also radicular futures. Radicular futures follow a nerve root distribution. Patients qualify the pain distinctly as sharp, shooting, superficial, lancinating. They use terms like electric shock. Those are clear terms that the patients use to describe their pain. Paresthesias may or may not be present, and usually it's worse with flexion. Better with extension. Obviously, radiation below the knee is very common. Objective weakness is possible, atrophy is possible, and there are positive root tension signs like a positive straight raised leg test. Workup, history and physical exam, including a detailed neurological exam. Diagnostic imaging. Playing fields are helpful to exclude a systemic pathology. Also for foraminal stenosis, tumors, infection. CT, MRI obviously offer better and greater resolution for identification of soft tissue. The patients may or may not also need EMG or nerve conduction studies if after the above workup there's still some debate about the diagnosis. Treatment options depend on the severity of the symptoms and the patient's preference. They include conservative management, interventional management, and surgical management. Conservative management includes back school, muscle relaxants, of which there's a broad class of them, exercise, behavioral therapy, traction, manual therapy, lumbar cassettes, TENS units, acupuncture. Medications, there's a whole class of medications that are used nowadays in practice. Some of them don't really work very well. For example, NSAIDs are not very effective with that kind of pain. Muscle relaxants are used oftenly, but again, are not very helpful, except for the side effects they pose to the patients. Systemic steroids are used. A lot of patients tend to get better from that, even though there are no studies suggesting that they're any better than placebo. There's also a class of neuropathic pain medications like Neurontin, Lyrica, Cymbalta, and Savella, which theoretically should help for neuropathic pain, and opioids. Interventional approach, caudal epidural steroid injections. Usually, there are different ways of accessing the neural axis for these epidural injections. Usually, caudal epidural steroid injections are usually reserved for patients who've had significant back surgeries where accessing the interlaminar space in the lumbar area is impossible. Lumbar transforaminal epidural injections are another way to do these interventions, as well as interlaminar injections. And let me just show you here. This is the anatomy of the epidural space. But this here is a interlaminar injection. Basically, you're going into the interlaminar space between two spinous processes. This is L5S1 interlaminar epidural steroid injection. Usually, the steroid is restricted to the posterior epidural space with these type of injections. This is a transforaminal epidural steroid injection. The needle comes from the side under the pedicle of the corresponding level. This is also called a selective nerve root block as well. There's also dorsal column stimulation with epidurally placed spinal cord electrodes, also known as neuromodulation. This is usually reserved for patients who failed conservative therapy and patients who are not going to be candidates for surgery. Basically, it involves placing specific electrodes at a certain level in the epidural space to then generate a sensation of tingling or warmth over the painful areas of the body. In this case, the lower extremities or groin area or back area. essentially you mask the patient's pain with a different type of paresthesia. This procedure, let me just show you a few things here. Here are the leads that are placed in the epidural space. These are the contacts. And these contacts are usually tunneled under the skin or attached to a implantable pulse generator. And the pulse generator usually needs to be recharged either on a weekly basis if they're a rechargeable pulse generator, or they have some that are not, that don't require recharging. Those are permanent generators that need to be replaced surgically every 2 to 5 years, depending on patient use. Surgical management. I'm not a surgeon, but usually surgical management is reserved for patients with neurological deficits that are present with that coincide with imaging studies that show. Excuse me, I got that wrong. Let me say that in a better way. Reserved for patients with neurological deficits where there's also significant pathology identified on imaging. These deficits can include motor deficits, sensory deficits, intractable pain, although most surgeons don't like to operate for intractable pain because it's not a very objective finding, as well as urinary bowel incontinence. Obviously, any evidence of cardiac Weiner syndrome should be managed quickly, and emergent surgery should always be considered for those kind of symptoms. So in conclusion, the evaluation of chronic lower back pain can be a daunting task. The possibilities are numerous. The diagnostic options are complicated and expensive. Fortunately, you can classify these into mechanical and non-mechanical back pain, and most of the back pain we see in the outpatient setting falls within mechanical lower back pain, 90% of it. We never want to miss the 10% of patients who have a systemic reason for their pain, and we've discussed several signs and symptoms and laboratory and imaging modalities that usually help us in trying to distinguish these patients. Treatment ranges from conservative therapy to interventional techniques to surgery. Also, be mindful that most of our patients with low back pain still have persistent pain a year later, and 10 to 12% have disability even after the first year. All right. Well, thank you. Any questions? Yes.
Are you aware of the new Medicare regulation that you have to prove the chronicity of the pain before you order an MRI? It takes 2 to 8 weeks.
Yes. Yes. I'm aware of that.
So what if you can't order an MRI unless you have documented treatment failure for 6 to 8 weeks?
I don't think that applies to if you have sensory neurological deficits, that does not apply. If there a lack of reflexes, motor deficits, sensory deficits, that does not apply. Any other questions?